So it's like any teaching station. You introduce yourself and welcome your colleague to the department, ask him if any problem he is facing and offer your help and support. Then ask him why he wants to know about episiotomy and appreciate his interest, and then put the agenda, and then ask him to stop you at any point if he needs more explanation or if he wants to ask any question. And also at the end you can offer him videos, links, especially on strategy, and some videos, and you can also offer him to attend with you if you repair an episiotomy. And you can also give him a feedback form to fill about your teaching session. So coming straight away to teach an episiotomy. So first of all, you have to tell him that episiotomy is an incision in the perineum, and we do it in purpose, so it is a deliberate incision. Okay, and it's not a routine cut in the perineum. It's only when we feel that we need to speed delivery, or if we have like a potential trauma to the perineum, so we guard it towards a safe area to avoid excessive tear. Like if we are conducting instrumental delivery like forceps, we need more space to avoid multiple trauma, so we can do the episiotomy, but there is no rule for routine episiotomy, and we have to know that. So we have two types of episiotomy. Either we have the midline episiotomy and the mediolateral one. Actually, the midline, as you can see, it's just a vertical incision in the midline. It's actually not done in UK at all because it's complication, because it's just straight away towards the anal sphincter, and it's actually easy and rapid, but its complication is more to involve the sphincter and possibly extension to third and fourth degree tears. So that's why we are not doing it in UK. We actually do the mediolateral episiotomy. As you can see, it's actually starts from the area of the posterior foresheet and going 60 degrees midway between the anus and the ischial tuberosity. Actually, it is designed to be 45 degrees from the midline, but because when you stretch the perineum during the crowning, this angle make the cut more towards the anus, so that's why we make it 60 degrees, so that we can be away a little bit from the anal sphincter. And usually to like have the correct angle of episiotomy, it is better to use the episiotomy scissor, not like that one. It's an angled one, and it's actually angled to measure the 45 degrees or 60 degrees accordingly. So you before you cut, you have to put 2 fingers inside the vagina to guard the scissor, so that you will not cause any injury to the fetal head. And you cut about 3 to 4 centimeters, but this when the perineal is fully stretched. Don't cut early episiotomy, because if you cut an early episiotomy, you will result in bleeding, more bleeding, and also it will not help the baby to come out soon, rather than if it is during the crowning, when the head is coming and not returning back. So the fully stretched perineum is the way when we cut, and also if it is fully stretched and thinned, the risk of bleeding will become less. Okay, so after you deliver the baby, and you can just start episiotomy, but before start suturing the episiotomy, we have to ensure that the patient put in lithotomy position. And this is very important because, you know, the patient here in UK is not necessarily to deliver in lithotomy position. She can just deliver on the bed without any lithotomy position. So if you have an episiotomy done, so you need her to be in a lithotomy position, okay? And also you have to be comfortable yourself, and the patient should be comfortable. So the patient should to be comfortable, you should ensure for her good analgesia. So you will inject a local lidocaine 1%. According to the extent of the episiotomy, you may need 10 to 15 ml. Okay, and when you inject the local, you should inject it before you cut. And so when you expect that you need an episiotomy, you have to inject the local and then you cut. Suppose the patient developed tear without you cut, and then you have to suture the tears, then at this moment you have to inject the local before suturing. Okay, so this is how the patient to be comfortable. So don't start suturing unless you feel that it is working and the patient can't feel the pain of the needle break. For you to be comfortable, you have to sit in the comfortable position. You have to ensure a good light for yourself so that you can visualize everything easily. So before you start suturing, you have to ensure that the count of the swabs, needle, and instrument is done and correct, because it's like a closed set, or we call it suture set. So when you open the suture set, there is like a paper, which is a checklist, is listed inside this paper, each instrument included in the set. So it will be mentioned like one scissor, one needle holder, one toothed forceps, one artery forceps, like that. Okay, so you just review all instruments included in a correct way, and should be another person with you to double check everything. Okay, and then everything is correct, then you can start suturing. So before you start, you have to visualize the apex clearly, and then we will start to secure the apex by securing the first suture behind the apex by like half centimeter or 1 centimeter. Okay, and we use Rectal Rapid 2.0 to suture the mucosa. Okay, so we have three things to be sutured: the vaginal mucosa and the perineal muscle, and then the perineal skin. We will start with the vaginal mucosa, so we will use Rectal Rapid 2.0. Okay, and usually we use continuous non-locking sutures for the vaginal mucosa, because it seems that it will be less painful, and we are not looking or doing any tense sutures on the mucosa to avoid like having forcibly tying or anything. We don't need that. We just need to ensure the approximation of the tissue, and also to ensure good hemostasis at the same time. So once we achieve that, that's enough. No need to forcibly tie or having like severely suturing with force, because this may cause ischemia and tearing of the vaginal mucosa. As you know, the vaginal mucosa, sometimes it may be friable tissue because of the pressure of the baby head during the second stage of labor. So we need to avoid tearing or laceration during suture. Okay. And after you finish the vaginal mucosa, try to ensure that you oppose the tissues in a correct way. You have a landmark at the outline of the vulva, which is the fourchette. You can just oppose two things together to be equal. And then you pass to the muscle, the perineal muscle. You suture the perineal muscle into layers. We have the deep layer and the superficial layer, also continuous non-locking sutures. And coming to the perineal skin, you can do it in a subcuticular suture, and it can be interrupted, but it is shown that the subcuticular continuous suture seems to have less pain and more comfortable and more cosmetic as well. You have to ensure that you close all the dead spaces because sometimes if you left a dead space inside, the hematoma may be collected. Okay, and also I forgot to tell you, it's very important to have a perirectal examination before and after suturing. So why we do it before suturing? We need to assess the extent of the episiotomy. Sometimes you cut episiotomy and after delivery this episiotomy may be extended to have a further degree tear, like third degree or fourth degree tear. Sometimes there may be buttonhole tear, and because everything is bloody, you can't see that it is extending. So if you do a perirectal examination before suturing, you will discover that. If so, we need to avoid any missing of these kinds of tear. So if everything is fine, then you change your gloves and start suturing. And after you finish, you have to do a perirectal examination again, and this is to ensure that there is no suture material passed through the rectal mucosa, because if this happens, this may increase the risk of having a fistula, and in this situation you need to remove the suture and resuture again. Okay. The issue is that after you finish, you have to ensure that all the swabs, needles, counts are correct, and you call another person who was with you in the beginning to double check, and you can like countersign that everything is correct, because if you miss a swab or anything inside, it will be a never event, and you know, if never event happen, it's a very big problem and the patient can claim for that. So this is very important. You know, during vaginal delivery, sometimes you may need to just block the blood coming from the uterus. So sometimes you may put a tampon inside and then you forgot to remove it. That's why I advise you, after you finish episiotomy, it's not only to do a perirectal examination, it's also to do a vaginal examination to ensure there is nothing inside. So you have to double check after you finish. Don't forget to do PV and BR. And after you finish, you have to document everything in the patient notes. If she developed any tear or anything, you have also to add, and what suture material you have used, and the extent and the method of repair and everything done. And you need to also debrief the patient and tell her how she will take care of her stitches and if anything to be done or no. And usually we need to tell the patient that it's like self-absorbing suture material, no need to remove stitches or anything, but we need to do the routine perineal hygiene, and we can give her some instructions. Also, we can ask the midwife to take care of her and to deliver the information to her community midwife. Okay, so after the patient discharge from the hospital, the community midwife will visit her at home for the first week. And if any thing like breakdown of suture or any suspected infection or anything, we need to instruct the patient to come and ask medical advice if this has happened, because usually we are not giving any routine antibiotics after vaginal delivery unless the patient is having any other risk factors like any suspected septicemia or anything. But for normal clean repair, we are not offering any antibiotics, so she has to take care and to seek medical advice if she feels that anything is not in the right way. Okay, so that's it. We need to be sure that if the patient develop any third or fourth degree perineal tear, should not be sutured in the room. She should be sutured in the theater by an experienced doctor. And before shifting the patient from the room to the theater, we need to count the needles, swabs, and instruments and close this set. And then when we shift the patient to the theater, we need to open another set to avoid confusion between the counts. Okay? Thank you.